Hello, Mark Testa here in Broomfield, Colorado with Regenexx Chief Medical Officer and Founder Chris Centeno. Today we're going to talk about Ask Him Anything. Ask Me Anything is the topic. Ask Dr. Centeno anything about regenerative medicine and stem cells.
Yeah, and I think you were talking, Mark, about, just discussing this week I did a post on David Singer. David is a chiropractic business consultant,
Right.
And we've been seeing more and more chiropractic business consultants get into the world of stem cells, and it's been interesting to see. What I found really interesting was on that post out of the blue, I think a sales rep actually put a comment on there that I think everyone should read, and it goes into, gee, now we have this stuff that David Singer's doctors, chiropractors are using, and the sales reps have been claiming that this umbilical cord product has millions of stem cells in it. Now the owner of that company that relabels that product is now saying she doesn't believe that it has many stem cells in it at all, if any. That's consistent with the research in this area. So what are they going to do with all these docs that bought this stuff, telling their patients they were getting millions of stem cells, which is what we've been talking about for years here, and that is that when we do research on these umbilical cord products, they don't have any stem cells in them. But now it's starting to come back around for some of these business consultants and relabelers and distributors and manufacturers, because they've been telling the people buying this stuff at the price of platinum, basically, that it's a stem cell rich product, and patients have been buying it as a stem cell rich product. So what recourse do those patients have and those physicians have when they find out there were no stem cells in this stuff?
Yeah, that's a great question. What recourse do they have? And it's amazing that so many people, bring in doctors to sell it, but don't really do quality due diligence to find out that there may not be anything in those.
Yeah, that's a huge problem. Again, if you're going to be making claims like that, you've got to have the ability to test those claims, because the buck stops here as the doctor.
Right. Guido asks, how many years away from FDA approval for stem cells, and will health insurance ever cover this?
Yeah, Guido, so when it comes to FDA approval for stem cells, it depends on what you're talking about. When it comes to bone marrow concentrate, that's taking your own bone marrow stem cells and using them right now. That's regulatory consistent and compliant at this point. So you can do that. When it comes to a stem cell product in a vial that really has millions of stem cells, I think we're a couple years away, but that's coming really quickly because of all the RMAT designations that are out there and are winding their way through the FDA process. And then we've got the idea of insurance coverage. We have about 7 to 8 million covered lives right now, Mark, I think, under Regenexx. So that means that we have lots of companies that self-insure that have decided to cover this stuff. Mark, who are some of our companies that you can think of off the top of your head? In fact, I saw that little graphic right there. So Hy-Vee, so if you work for Hy-Vee, that's a large grocery store chain in the Midwest. All this stuff is covered. If you work for Time Inc., all this stuff is covered. That's the magazine that we all know. Dean Foods, they make milk products.
Michaels,
Dillard's,
right?
Michaels. You've seen Michaels in your area. Dillard's, you've seen Dillard's stores. These are all employees that work for these companies that have full coverage for Regenexx, not for PRP, not for stem cells. You can't get your stem cells covered at a chiropractic office, but at Regenexx facility, they've got full coverage. So that's slowly but surely coming.
Sure is. It's exciting. Kevin asked about if you have cervical instability and you get treated, can you ever get back to 100%?
Yeah, Kevin, that's a good question. It all depends on the type of cervical instability. If it's traumatic cervical instability, have we seen patients get back to 100%? We have. Probably having said that, that's a spectrum, right? Of everything from mild to moderate instability to severe instability. So I just saw one of my severe traumatic instability patients back. He had about 7 to 8 millimeters of C1, C2 overhang to one side. He's doing great. He's doing most of the things he wants to do. Is he perfect? He's not. But this is a guy who went from pretty much doing nothing to now hiking for miles and miles. In fact, he was complaining about his knees need to be treated, and the reason why he brought up that his knees need to be treated was because he hasn't been in a position for the last 5 or 6 years to do enough to stress his knees in any way. So it all depends on where you are. This is not magic. This is the PICL procedure. What you're talking about is a specific procedure. It's got a success rate, a failure rate, and it's changed a lot of lives, but it's not magic pixie dust.
And Guido, I'd like to encourage you to follow up with Regenexx Corporate. If you work for Station's health plan, this is something they're probably self-insured, self-funded. We could potentially add to that plan. Bridget asks, how many injections do you typically complete on an individual with EDS, presenting problems, cervical spine instability? And could you tell us about what EDS is?
Yeah, Ehlers-Danlos syndrome. So it just means you were born with very stretchy ligaments. As EDS patients get older, they tend to see lots of different problems related to instability, meaning ligaments cause too much motion in joints, and that leads to pain and disability. When it comes to craniocervical instability or laxity in the ligaments that hold the head on, generally for that PICL procedure that is being discussed here, 2 to 4 treatments are average for where we are right now.
All right, great. Carson asked about scapular detachment. Would this be helpful? I don't know if we need more of an explanation.
Yeah, let's get a little bit more explanation. Detachment, are you talking about a specific muscle that has detached from the scapula? Are you talking about the scapula is not moving correctly? Are you talking about a scapulothoracic bursitis? I just need a little bit more info.
Ancho asks about how effective this is for hip treatment.
Yeah, very good question, because hips are very, very different than knees. So for knees, we can take anything from mild to moderate to severe. In hips, this works well in mild and moderate hip osteoarthritis, but once you get into severe hip osteoarthritis, a same-day bone marrow procedure isn't going to cut it in most patients. Most patients are not going to get great relief if they've got severe hip osteoarthritis with any orthobiologic procedure, whether that be PRP, bone marrow stem cell procedure, magic mushroom, umbilical cord stuff, whatever you want to call it.
Yeah, right. We've seen somebody else I work with has had a complete failure, 80-year-old mom with amniotic in the hip.
Yeah, and again, they should have known that had no chance of working in that patient, but they didn't. Why didn't they know that? Because they went to some weekend course, the patient had the money, so they pulled the trigger on it. We would have told that patient, you're not a candidate for this, go get a hip replacement.
Yeah. Carson says rhomboid is partially detached from the scapula along with bursitis. Yeah,
so so I need to look at the MRI. If it's physically detached and retracted by quite a bit, then this kind of procedure is not going to reattach it. If it's just a, quote, complete tear that was read out on the MRI that way, regrettably, most of the reading radiologists won't say whether or not it's retracted. So we'd have to look at those images and see if you're a candidate for this kind of thing.
Right. Great. She also has a hip labral tear and am ACL deficient. Carson, what do you think about those sorts of conditions?
So hip labral tears we treat all the time with this type of technology, whether it be PRP or bone marrow concentrate. When it comes to an ACL deficient knee, depends on what's wrong with that. I'm assuming you've had an ACL tear and either got repaired and failed or wasn't repaired at all, in which case we'd have to figure out what's causing the pain. We're not going to regrow you a new ACL if there isn't one there.
And I'd like to encourage you, if you know someone you work with, a loved one who's looking at potential orthopedic surgery or has ongoing musculoskeletal pain and they're looking for other ideas, share this Facebook Live with them, and hopefully we'll answer a question that pertains to them. Bridget asks, if you have bone-on-bone hip arthritis, is it worth it to obtain an MRI if you only have an X-ray?
I mean, from our standpoint, the only thing that we would even consider doing in a patient with bone-on-bone hip osteoarthritis would be the culture expanded procedure down in Grand Cayman. And we would need an MRI to see how damaged the bone is, meaning if the bone is more damaged on the MRI, and that's actually going to show more subtle changes in the bone than an X-ray, then that patient would not be a candidate even for that procedure. But less damage they would be.
I know a lot of people ask what kind of imaging we do like. Will an X-ray suffice? Does everyone always need an MRI? What are your thoughts on that?
Yeah, a lot of patients don't need MRIs because we can look at this stuff very easily in the office using ultrasound. So for instance, a shoulder rotator cuff tear, many times we can get all the information we need from ultrasound. Whereas in this case, hip osteoarthritis, that's the other end of the spectrum. We're looking for specific changes in bone, and an MRI is actually more sensitive to pick up those kinds of changes.
Diane asks, does Medicare cover Regenexx treatment?
No, Diane, not yet. I suspect that one's going to be a while. That's usually the last domino, so to speak, to fall. Usually you see private health insurers who are self-insured start to add things because they think it's better for their employees and they've got much more control. Then you'll see some of the major insurers start to do pilot programs. Then you'll see a couple of them start to do it, and usually the last domino to fall is Medicare or Medicaid.
Great. Okay, let me see here. Angus asks, I had an X-ray guided hip SI joint injection with 100% immediate relief from the lidocaine. Oh man, it scrolled past too fast. I'm sorry we didn't get that. Would you mind reposting that or move that back up to the top? I can't pull all these out.
So Angus, maybe I can guess what you're asking. If we know it's your SI joint that's causing the pain, then the next big issue is either it's been an SI joint injury or the SI joint is unstable. If the SI joint is unstable, we need to treat the ligaments in addition to that joint surface. And that's usually what we have clinically. So usually that's how we'll approach that. Some of those patients do just fine with platelet-based treatment. A few of them need bone marrow-based treatment. But quite a bit of those patients will do well with just platelet-based treatments.
And Kathy asks, what limitations would a patient have after a bilateral stem cell in the knee regarding braces or movement or activities?
Yeah, I mean, when it comes to bilateral injections in the knees, generally you're going to go down hard for a couple days, not do a lot during that time. Then you're going to be allowed some limited activity with your braces on. And what I mean by limited activity is you can go out and walk a mile or so. You can do things like an elliptical, those sorts of things. But we're not going to want you running or cutting for 6 to 8 weeks. So that's generally how that plays out. Excuse me.
Michelle asks about if we can regrow cartilage.
Yeah, Michelle, it all depends on what it is we're looking at. So when it comes to small holes in the cartilage, the answer is that we have seen cartilage in those instances regenerate with some of the technologies we use. When it comes to if you've got severe loss of cartilage from severe arthritis, let's say in your knee, you're not going to see cartilage regrowth. In fact, all the chiropractors out there that are advertising that are scamming the public. What they're doing is they're changing the angle of the X-ray beam to make it look like someone has regrown cartilage. And it's an awful thing because I've seen countless patients on Facebook convinced on a stack of Bibles that they have had huge stretches of cartilage regrown in their knee, when in fact all their chiropractor did is tilt the angle a little bit to make it look that way. So, regrettably, an x-ray is not something you should use to look to see if you've had any increase in cartilage. That's an MRI. We have thousands of MRI scanners in this country. There's no reason why you wouldn't get a follow-up MRI, but there's a reason why these chiropractors aren't getting follow-up MRIs, because it doesn't happen. You got to tilt the beam and scan the patient to play that game.
Which follows along a question Precious has. Do we do before and after imaging?
We do. So I know what Precious is interested in just from Facebook. Yes. So, for instance, with that PICL procedure, we will do before and after imaging of the C1, C2 overhang or the atlantodental interspace. We've done quite a few of those actually, and we are looking for changes in motion there.
J. Marr asks, has pain when standing from sitting for a while? What might be wrong, and could a Regenexx injection help?
Yeah, talking about back pain, standing from sitting, or?
Yeah, no specifics other than that.
So let's assume it's back pain. If it's back pain going from, sitting to standing, normally what we're seeing there is a facet problem. So the facets tend to swell when you're sitting, and then when you go to stand up, they're a little bit swollen and they hurt. So that's usually a platelet-rich plasma-based treatment, and I've had that issue personally, and that's how I've had it treated through Regenexx. If you're talking about knee pain after standing, going from sitting to standing, that's usually osteoarthritis in the knee, and that type of thing would depend on how severe the arthritis is. If it's more mild, PRP. If it's more severe, stem cells.
And Kevin asks, he had a meniscectomy, still has some pain in the knee. Can anything be done for this since we can't regrow the meniscus?
Yeah, Kevin, so when it comes to trying to get a bigger meniscus, there's been some studies that we published and another group published that sometimes with culture expanded stem cells, like the kind we used down in Grand Cayman, you can see the meniscus get bigger. But that's not a reliable finding. If you have continued knee pain, though, after meniscectomy, it's probably caused by something else. So that might be a loose ligament that's causing the meniscus not to act as a shock absorber, or swelling in the bone itself, called the bone marrow lesion. So the answer is we treat a lot of patients like that are post-meniscectomy who do very well, but we've got to first figure out what's causing their problems.
Similar, well, you mentioned Regenexx C. Someone asked about Linda asked about the cost of that, storage, and re-injections, and how many re-injections could they potentially get out of banking?
Yeah, so Regenexx C is by far the most expensive thing we do. That's where we culture cells at a licensed site in Grand Cayman to much bigger numbers. So for instance, we could get, let's say if you had a knee problem and we were treating a knee problem, the average person is probably going to get somewhere between 3 to 5 treatments banked for that knee. Now that can go all the way up to 10 or 12 treatments. So it just depends on how well your cells grow in culture. But that's much more expensive. That's in the $20,000 range. Whereas if we were looking at a same-day procedure for that knee, that would be a third of that much. And if we're looking at a platelet-based procedure for that knee, that would be a third again as much. So that's definitely the most expensive procedure we offer. But you can bank cells for future use, which is a nice advantage.
Gladys asks, and this is a little in-depth, she had DMX, had slippage on both sides and an ADI space of 5 millimeters. Can you explain what this means, and would a PICL treatment be helpful?
Yeah, Gladys, so if you have those kinds of motions, normally it's laxity in the transverse ligament and laxity in the alar ligaments. And those numbers don't concern me with regard to us being able to tighten down those ligaments given what we've seen in the past. So I don't think we'll see a problem achieving the goal of getting that atlantodental interspace less. The ADI means atlantodental interspace. It means as you move your head forward, the transverse ligament is loose, so the dens is kind of coming off of the atlas, or the C1 and C2 bone are moving too much. So that's in the frontal plane, meaning looking down. Whereas if we're talking about C1, C2 overhang, that's with you bending your head to the side. So atlantodental interspace is looking down. C1, C2 overhang is bending the head to the side.
Here's a question from Linda. She said she has heard of orthopedic surgeons at acclaimed hospitals getting paid for regenerative medicine using codes that were non-experimental procedure codes, and would we be willing to do anything like that?
Yeah, regrettably, is it Linda?
Yes.
Yeah, regrettably, Linda, that one comes with a possible creative coding award, which includes an orange jumpsuit and time in federal prison. So I don't care where you are or how acclaimed the place you work is, you still get to go to federal prison if you get a creative coder award. Meaning that there are no codes that reimburse for this stuff. So if those doctors and those hospitals are doing that, they could well end up in federal prison for doing it, meaning that you can't make up stuff when you send it to an insurance company, meaning that you can't say something is X and it's really Y. If you do that, that's billing fraud, and in most states that will put you in federal prison.
Yeah. So we won't be doing that.
No, we don't. I have no desire to spend the last 20 years of my life serving time in an orange jumpsuit.
No. Kevin asks, with Regenexx C procedures, is storage paid for annually, or is that cryopreservation for the life of the cells?
It's paid annually. So there's a storage fee of, I think, a couple $100 a year to store those cells down at that Grand Cayman site. And I don't know how many patients have their cells stored down there. It's got to be hundreds and hundreds. At this point, maybe 1,000 or 2,000, somewhere in there.
Kevin asks, should the ADI with a neutral head, what should the ADI with a neutral head position for be? He knows it moves with flexion.
Yeah, it generally shouldn't be more than 2 millimeters. So if it's 5 millimeters, that's definitely too much, but shouldn't be more than 1 or 2 millimeters at most.
Randy asks, can PRP reverse arthritic changes in the facet joints, low back, lumbar area?
Yeah, Randy, I don't know that PRP can reverse those arthritic changes. When it comes to PRP, your goal is usually trying to prevent the arthritis from getting worse and managing its effects. So as an example, I've got arthritic facet joints at L5S1. I've got a little bit of a spondylolisthesis. What we were able to do is to get the spondylolisthesis back, meaning spondylolisthesis is when the L5 vertebra, in my case, slips forward. So now that's reduced and that's stable, and we're working on those facet joints. I'm not going to get new facet joints in the bargain, but I'll certainly have much less pain in those joints. The microenvironment will be better, and perhaps we'll grow some new cartilage cells in there, but I'm not getting new facet joints out of it.
Lisa asks, she had stem cells in Caymans in July, 2 torn ACLs, 1 torn meniscus, bone on bone. Left knee has developed a clicking or misalignment. She's not sure. Is this part of the healing?
Yeah, I think that would be a good one to have your doctor, or talk to your doctor about, and or have someone take a look. What we will see sometimes is as the knee tightens up and those ligaments tighten up, certain things can start to click, because if you think about it, clicking is nothing more than a high-pitched sound of something that is not quite tight enough, but it's pretty tight, whereas when it's very loose, you don't get that kind of clicking. So we definitely see patients who go through that clicking phase, and that's something you want to have your doctor take a look at. If you're local to that doctor, or maybe there's a local Regenexx doctor there who can take a look at it for you.
Mark asks, how can a vagus nerve compression be diagnosed? What vertebral segments can cause vagus nerve compression? Is it in the cervical spine, or could it be in the thoracic as well?
Yeah, generally if it's upper cervical instability, vagus nerve compression is not uncommon. It's normally diagnosed by ventricular tachycardia. So the patient has a rapid heart rate that will generally get a little bit better when they're in and they've been adjusted, and get a bit worse in certain positions. The vagus nerve goes right by the craniocervical junction as it exits the foramen magnum there. So it's right there. And in fact, if you were to see Scott Rosa in New York, who I would highly recommend, Scott is the world's expert on imaging the CCJ area and looking at cerebral spinal fluid flow with his MRI up there. They frequently diagnose for vagus nerve compression in CCJ patients.
Michelle asks, what is the benefit of PRP 6 months after a stem cell injection? Don't know what body part.
Yeah, I mean, generally what we're looking at there is sometimes we get into this concept of booster shots. So one of the things that the research is starting to tell us is that there may be value in repetitively hitting these joints. So for instance, research showing, close it on me. Research showing that hitting the joint twice is better than hitting the joint once, or 3 times better than once. And that's probably because the first injection is setting up the environment for the second injection, and so on. So that's generally why we'll recommend that sometimes when someone doesn't have a complete response, because sometimes they will get a complete or a much better response than they would have just from a PRP injection, because one injection is building off the next.
Simran asks, some doctors before DMX numb the muscles, and what are your thoughts on this, and could it be causing further damage?
Yeah, what I've not heard of yet. I don't think I'd recommend that, because most CCJ patients can really get in trouble if they move their head the wrong way. So if you numb those muscles, you're not really going to be able to feel what it is you're doing. So I don't think I'd recommend that at all. Now, if a patient has a severe amount of tightness, taking a Valium before the procedure is probably a better way to go. 10 milligrams of oral Valium will generally relax their muscles enough where they can get some good range of motion for the study. But I don't think I'd recommend numbing the muscles, because I would be very concerned that many CCJ patients might injure themselves like that.
Randy asks if there's anything new in this space, any new news, any new interesting things in this area that you're excited about. I know we were just talking about some before we turned on the camera, some of the research on PRP.
Oh yeah, I was just talking to Mark about how, I wake up at 5 in the morning. That's when my day starts. I start writing at 5. And for many of the blogs that I do, I'm looking up, various research on the U.S. Library of Medicine. And one of the things that's blown me away, I was telling Mark in the last couple of weeks, is the sheer volume of studies that are coming out, small to medium to even larger size randomized controlled trials with PRP. As an example, I was doing one on carpal tunnel syndrome that I think I published this morning on the Regenexx blog. And there were 2 randomized controlled trials published on it. I expected to find nothing published, and I found 2 randomized controlled trials on PRP and carpal tunnel. Today I was writing one for the Centeno Schultz blog, and there was a randomized controlled trial for hand CMC for PRP. So it's kind of blowing me away that these are coming out. They've all been out in the last basically couple of months. So PRP literature is really maturing rapidly, and it's great to see that there's so many different studies that are being published out there, and it's starting to blow me away a little bit, because I go into the literature and I look for something and I expect to see nothing, and the next thing you know, I find 2 randomized controlled trials. So I'm like, wow, this is crazy. So again, just so that you know, we have this much research on PRP right now. We have that much research on bone marrow concentrate, and we've got that much research on umbilical cord stem cells. Meaning we basically know nothing about umbilical cord stem cells that are being delivered through these commercial products. Again, there are no stem cells. That's all a scam. It's a dead tissue product, but we have zero or next to zero information. Now that'll change over the next number of years. We'll see more and more get published. But right now, if you had to look at what's got the most published in the literature for helping your pain, it's PRP.
That's great. Since you mentioned CMC, and I don't know if, John, you had this done on your thumb, my left hand is notably stronger and more coordinated since I had PRP in late May. Hand feels much healthier than it has been in 2 years. That's great.
Yeah, I think I know which John that is. You know, that procedure, John, has amazed me. We developed that procedure probably 4 years ago. So our history there was we were using stem cells for CMC arthritis. We were getting really nice results down in Grand Cayman, but it was very expensive to bring patients down there. So we started looking at rejiggering how we did the procedure, doing completely different than everyone else does. Everyone else would just inject inside the joint. We started looking at that, plus injecting into the tendons and ligaments that surround the CMC or the base of the thumb joint, and also treating the median nerve here with different types of PRP. And that procedure has blown me away on how well it works on patients who really need surgery. So it's been really nice to see.
Let's see. I'm sorry. Heather asked about if this would be beneficial for autoimmune conditions.
Yeah, Heather, it depends on what we're talking about with regard to autoimmune conditions. Meaning, do we have any research right now that using stem cells are going to cure your autoimmune condition? The answer is no, we don't. There are a number of different stem cell type plays to treat autoimmune conditions. One would be some of the stuff that was being done by Richard Burt at Northwestern, where they basically kill off the bone marrow space and then reboot it with a bone marrow transplant. That was working very well in patients, for instance, with autoimmune related MS. Apparently that's just gotten shut down recently, so that's not happening anymore. I just heard a couple weeks ago. But you know, as far as getting an IV umbilical cord infusion to treat your autoimmune stuff, I don't know, it might work, but there's no information on it right now that shows that it would work. And you're just as likely to get graft versus host disease from a mismatched umbilical cord product as you would have it be incredibly successful.
Dennis asks, he had 4 herniated discs in the neck, had plated fusion with 2 levels fused, headaches better, numbness down the fingertips is improved. Should he look into stem cells or something else, orthobiologics, or is he past the point now that he's had surgery?
Yeah, Dennis, we see a lot of patients who have had fusions who have continued pain or do well and then get increased pain. That's usually because of adjacent segment disease. So that means that you've got the area that's fused that's not moving at all, and above or below and above, it starts to move too much. So we treat those patients all the time. They do well, but we can't cure their fusion, meaning that their fusion at some point can start to cause more problems above and below. So we can treat those areas above and below. We can, breathe more life into them, if you will, but we can't reverse the fact that there's been a fusion.
Regina's a massage therapist, wonders about stem cells for her hands so she can prolong her career.
Yeah, so for most patients in their hands, we're actually using high-dose platelet-rich plasma, and it works very well. Sometimes we'll mix that with an A2M cytokine product that we offer, which is anti-catabolic, anti-breakdown. And then only every once in a while we're using stem cells in those situations. Normally for massage therapists, physical therapists, chiropractors, dentists, people that use their hands a lot, you tend to see instability in those small joints. So you not only have to inject the joint, but under ultrasound guidance using a very small probe and very small needle, you've got to actually inject the ligaments to get those tighter to make sure that the joint will function normally. And that's doubly true in women who tend to get more instability related hand OA.
Murhi, I'm sorry, I'm saying that wrong, wants to come to Colorado to get treated, doesn't speak good English. Is there anyone who can help him with German?
I don't think we have a native German speaker here. I speak bad high school German, so I'm happy to try. But I don't think we have a native German speaker here, but happy to certainly try. Again, I had a crush on my German teacher in high school for all 4 years. I took 4 years of German, so I will do my best.
All right. That'll help you learn German.
It will. It was the only one of the few classes. I took Spanish and German at the same time. I did much better in German.
Right. What's the downtime? Regina would like to know, what's the downtime on the hand thing?
It really depends. I mean, most of these patients aren't having huge downtime. They might have a lot of pain the first night or two. So as an example, if you're a massage therapist, I would think that if you did it midweek, took off a Thursday and Friday and the weekend, you'd probably be good to go by that Monday. For instance, that's what I would do with some of the local physical therapists, Chris West being one. That's generally how we would sequence that.
Randy asks, can PRP help with overall soreness and overtraining? My legs don't recover like they used to, calves and things. Would PRP injections in these areas help with recovery so he can train more?
Yeah, I doubt it. Well, let's just say we don't have any information that would help at this point. And a concern there is we're now moving from treating something that's injured into what WADA, the World Anti-Doping Agency, would consider enhancement. So that's also crossing an ethical boundary we wouldn't cross.
Let's see. CCJ, would you advise that people return to normal life between procedures if they need to have multiple procedures without being super protective to the area? How many months post-procedure would normal loading of the CCJ ligaments be safe? So, after they've had a few.
Yeah, realize that, so there's a couple things with that procedure. One is if someone is out there and they're doing well, for instance, with chiropractic adjustments, but only on a short-term basis, we'll want them to continue that. We'll want them to increase their activities as they feel able. So let me give you this one woman's history. It's kind of interesting. She had first CCJ procedure, got a little more active. Second CCJ procedure, got a little more active. After her third, she actually started some aggressive, forget what it's called, but it's a type of training where they put you in this little device and they turn you upside down. And the concept is you're constantly moving your neck around to get to a target. She started at a very low level. She eventually got to the mid levels. There's high levels for athletes. So that was her journey. By the third procedure, she was able to do much more aggressive physical therapy. In fact, when I first heard that, I really, it was one of those times where I said, what are you doing? Why are you doing this? But it was incredibly helpful for her to get those muscles stronger. Compare that to another gentleman who was a chiropractor who was spending 1 hour a day vertical and 23 hours in bed. We were able to get him back to work, and he has to spend now about 2 hours, 1 to 2 hours a day, broken up through the day laying down. And he's only now, after 4 procedures, getting to the point where he can start to do some upper cervical rehab. So it's everyone's journey is different, but we want you to be as active as you feel able.
I'm going to ask a follow-up question to Randy's on his legs, calves, and recovery. Could that be something degenerative, irritated out of the low back, those nerves just not working as well, that could be helped?
Yeah, so Randy, as Mark's probably pointing to, is I've written a couple blogs on heavy legs, and that is, and I've experienced this myself, when my low back nerves get irritated, my legs feel heavy, they don't recover as well, they get sore. I'll get a platelet lysate epidural here, and the next day or the day after that I'll be bounding up the steps. So realize that yes, there can be low back inputs there. Now try to treat that conservatively. See a high quality physical therapist. We've worked with the IPA group. So if you search IPA physical therapist, you'll see these folks come up. They're kind of super specialists in the musculoskeletal system. So that's something to explore.
Mary, if you contact our education center via email, we will be able to help you find a hotel and get information over here to this clinic. I think Carrie can maybe put that in the notes following your question.
Yeah, we see about half the patients we see are not from Colorado here in Colorado. So obviously we have many different hotels we work with in this area, and we do a lot of phone reviews, looking at patients' MRIs, talking to them about their history, and trying to get a sense of whether or not we can help before they come out here, because it's very important to us that you don't come out here unless we really feel we can help you.
Right. All right. Let's see. Can you get PRP lysate epidurals?
Yeah, we use, platelet lysate epidurals. So just so everyone understands, we've got PRP, which is concentrated platelets. Then you can take the growth factors out of those platelets and just suspend that in the plasma, and that's called a platelet lysate. And generally that's what we'll use around nerves. So we'll use platelet lysate for epidurals, and we do hundreds of those every month here. And we'll use more PRP in joints and for tendons. But when it comes to treating nerves or around nerves like epidurals, our go-to is platelet lysate.
Gladys asks one more time. She had upright MRIs, showed pretty bad pics of the alar and measurements of 4.19 millimeters in neutral, weight bearing, and is no longer, and it's no, these are moving fast here. It looks like it sorry, went off the screen. So upright MRI.
So Gladys, if you could repost what 4.19 is a measurement of, because there's lots of different measurements in the upper cervical spine, Grab Oaks, clivo-axial angle, Powers ratio, etc. So let me know what that means. But when it comes to upright MRI and looking at the ligaments themselves, that can be one of the ways we identify whether or not the ligaments are damaged. But we also usually want a movement-based study as well. So an upright MRI with flexion or extension, or a DMX where we're looking at flexion, extension, and lateral bending, those sorts of things.
All right, hold on. We're running out of battery here soon. Okay, so yeah, okay, 4.19 millimeters in neutral weight bearing, and it is longer than my right side with grade 1 of 3 ligament signals. Left accessory alar is at least 1.23 longer than my right with second grade signal, and a lot more no good news.
Yeah, Gladys, I think the best thing to do would be a phone review so we can take a look at those images. I think what you're talking about is some of the Crockiness scale, grade 1, 2, or 3 changes in the alar accessory or transverse ligament complex. Usually those grade 2s are where we start to pay attention for sure.
All right, very good. So we're running out of battery here. Not a good reason to have to end, but it's true.
Let's take 3 more.
Okay, let's do that. Okay, Gladys says clivo-axial angle, 120 in flexion.
Yeah, so that would be abnormal. So Gladys, again, that's the kind of thing that we'd want to take a look at those images. We'd want to do those measurements ourselves as well. And happy to do that through a phone review where we can discuss your history.
Right.
Because again, for us, realize there's measurements, but then there's all of those measurements have to fit the history and or response to treatment, meaning that all of this is a big puzzle. And it doesn't matter if it's craniocervical instability or knee osteoarthritis or why your back hurts. There's the imaging, and then there's the history, and then there's response to treatment, and all of that creates a picture for us to see how best to help you.
Kevin asks if T3 image MRI is better than an upright MRI.
Yeah, so 3 Tesla just means the field strength. And the nice part about that is you're going to get very good information, high quality images, and high resolution. The downside is that's a closed bore magnet where you can't have anyone move. So we tend to like upright movement-based MRI for instability-related issues more. So if we're talking about craniocervical instability, we'd probably rather an upright MRI. When it comes to looking at where the cartilage is good in the knee, a 3 Tesla MRI is better.
Also, Kevin asks about if a platelet lysate epidural would help reduce a bulging disc. He's, I think, maybe seen that on one of the blogs or talked to another doctor who might have mentioned that.
Yeah, so if it's a herniated disc, we've seen platelet lysate epidurals work to reduce that herniation size. Now realize that many herniated discs will kind of get smaller on their own as well, and all this is probably doing is helping that process. When it comes to a bulging disc, which is more where the outer wall of the annulus is injured and it kind of pushes out, that's something that will generally take an injection of stem cells into the disc if we're trying to get rid of that bulge. And that injection would need to be into that disc annulus, those fibers that are damaged. So it just depends on what we're talking about there.
All right, great questions. Any final thoughts before we wrap up?
Yeah, as I always say, this is one of those areas where you really, really, really have to do your homework. We have a documentary filmmaker that we know that's been working on a documentary in this area for the last year, and I think he's finally going to start wrapping it up. But I was talking to him the other day. He was asking me some more questions, and that was his conclusion. He was like, man, after studying this stuff for a year, it's crazy just as a layperson trying to learn all this and understanding how easy it is to get taken and scammed. He now understands all that. He's been looking at this stuff for a year, and that was what we were talking about was, this is one of those areas where you just got to do your homework. So it's great that you're on here doing your homework, and we'll see you next week.
Yeah, we'll be back next week. Thanks for tuning in. If you know someone looking for solutions, please share this with them so they can find out the truth from the fiction. All right, we'll see you next week. Thank you.